is there any specific data that would, in your mind, just solidify luspatercept as the treatment choice in low risk MDS in the first line setting? What do we need to make it a primary treatment in the guidelines for the payers?
I'm not sure we need anything beyond what we have. I think we need people to actually, pay attention to and know about the data. And the problem is there's too much data, too many drugs, too many diseases. I really cannot imagine what it's like to be a more community-based oncologist having to know how to treat everything. It's not possible to keep up. So, the challenge here is to make sure people are aware of the floridly positive randomized phase 3 data from commands, and now the follow-up data pointing to more and more benefits, suggesting that really we should have, a year or two ago replaced frontline ESA with luspatercept. But each time we talk about this, each time I ask folks what they're doing, more and more people are doing just that. It just takes a while to actually change practice.
Definitely. I think the other thing too, in addition to that, one thing I've thought about frequently is you look at higher risk MDS, those patients are going to be referred to the larger academic centers for evaluation of transplant. The lower risk MDS may never leave the community. And so they get fewer reminders from us, higher risk MDS. I'm always working with our community partners and, hey, we're doing this now, or we're adjusting this and reviewing some of the data that's there. But lower risk MDS, I may never see them. And so they may get fewer reminders of some of the newer updated data that may be out there. And so I agree, it's an incredibly challenging job. And I say that I'm not smart enough to be able to do community oncology because it is such a complex, challenging scenario. But I think to keep up with the lower risk MDS patient population, they may just be comfortable with ESAs. It works. They get enough, to go by, and that's maybe hindered some of that spread.
I would say I'm impressed as well. I think that over time, the utilization has increased. I say slowly, more people using luspatercept frontline. I think in the beginning, the biggest problem was dosing, that patients would start on that standard 1 mg per kg, and they would never have a dose escalation. And I see there's a greater recognition that people are understanding that the majority of patients will require at least 1 dose increase to achieve their maximum hematologic benefit. So I saw a big change over the last few years. So I'm happy to say that it is challenging, but I think slowly but surely there's better utilization of the medication.
Yeah, and one thing in talking to some of my community partners that I hear a lot too, the reason it hasn't spread more is still the thought of the ring sideroblast, needing a ring sideroblast. And I try to re-educate that that's no longer a barrier, and that everybody with low risk MDS with anemia should consider luspatercept. And so I've tried to get that message out there. I think that hinders it to some degree, but because most people are aware of it. But I also have seen the past 2 years, really things have expanded.
I think it was mentioned already by Dr. LeBlanc, Maxilis. So why not, instead of starting at 1 mg, start at the 1.75 mg per kg dose? And I think at EHA, they were showing some early results, and the responses are really good for ESA naive and also ESA refractory patients. So I'm also excited about, can we find what is the ideal dose for our patients who are on it? And also another way, what about when to start luspatercept element? Right? What about patients who are not requiring transfusions? And I think an element, your hemoglobin had to be 9.5 or less, but that will give us more information on what's the optimal timing. So I'm excited about both of those trials.
Yeah, why wait till someone gets transfusion dependent and they feel really badly? If we know they have low risk MDS, the hemoglobin's going down, they have some symptoms, maybe it's better to intervene sooner. Maybe you get longer response rate. We don't know. But yeah, I share your excitement about Maxilis too. And to add something to that, I worry that the kinetics of when you see your maximal benefit with luspatercept are part of what prompts people to discontinue it prematurely because they sort of just don't know what to expect. And with more experience comes familiarity. But if you look at the response timing with ESAs, in fact, now the NCCN guidelines say 6 to 8 weeks, no response stop, you're done. You're going to see what you're going to see within 2 months of starting an ESA. That's not the case with luspatercept. If we have to dose escalate slowly, you give every 3-week doses, you have to give at least 2 at each dose level, which means that you're almost 2 months in at that point before you're escalating to the next dose level, and you're not really seeing the maximum dose level for several months beyond that. And that might be where the patient gets the benefit. So they might have side effects up front without the benefit yet, and they want to quit. And it's challenging. They haven't seen the perks of the therapy yet. So if we could just start at a higher dose that's more effective, I bet we would have fewer people stopping this drug prematurely. I still do see a decent bit of that, unfortunately.
And I think, to me, I'm very excited about the Element trial. I mean, I in my practice do still use luspatercept in patients who are anemic, not quite transfusion dependent, because I do still see a benefit. And I understand the argument that you're committing somebody to something that they otherwise did not have a commitment to, with not requiring transfusions. And I certainly respect that point of view. But to me, knowing that you can prevent or delay that transfusion dependency, do we see a survival benefit there? I don't know. These are questions that I think would further that argument and further that discussion. So I'm really excited to see that data emerge.